Welcome to the Deep Dive. We're here to take complex topics, break them down, and give you genuinely useful insights so you can be truly well-informed. Today, we're tackling something, well, universal, but often kind of uncomfortable to talk about. Common genitourinary, that's GU, and gynecological, or GYN, health concerns. Understanding these isn't just about symptoms, it's really fundamental to your overall well-being. So our mission in this deep dive, to give you a comprehensive look at how medical professionals assess, diagnose, and treat these common GU and GYN problems. We've gathered insights from expert medical sources to really shortcut your understanding here.
And that's precisely why this is so valuable. I mean, think about it, understanding the specific signs, knowing when you need to seek care, what to actually expect. That knowledge really empowers you, doesn't it? It shifts you from just being a patient to being an active participant in your own health.
Okay, yeah. Let's unpack this then. Let's start with some really common vaginal conditions. We're talking Candida vulvovaginitis, bacterial vaginosis BV, and genitourinary syndrome of menopause, or GSM. Now, on the surface, the symptoms might feel pretty similar, right? But the sources show they're actually quite distinct when you know what you're looking for. Okay, so Candida vulvovaginitis. The usual suspect here is Candida albicans. That's the yeast causing what? 80 to 90% of cases. You often get that classic cottage cheese like discharge. And itching, burning, pretty uncomfortable. And here's a key thing for your doctor. Under a microscope, they're looking for pseudohypha. Those are like the thread-like shapes of the yeast. That small detail is critical because it screams yeast, not bacteria. Totally changes the treatment plan. Usually it's an azole antifungal, right? Pill or cream.
Exactly. It's a very targeted approach based on that finding.
Then you've got bacterial vaginosis, BV. The cause is, well, it's a bit less clear-cut. Probably polymicrobial, a mix of bacteria like Gardnerella vaginalis, Mycoplasma hominis, basically an imbalance. Here, the discharge is different. Thin, homogeneous, white or gray, maybe more discharge than usual, and that distinctive fishy odor. The sources say it's especially noticeable with a simple whiff test, sometimes using KOH solution to, amplify it.
Right, the amine odor test.
Yeah, and microscopically, clue cells, vaginal cells just covered in bacteria, basically telling the doctor what's up. Treatment often involves metronidazole or clindamycin, topical or oral.
Two quite different pictures already.
Totally. And third, genitourinary syndrome of menopause, GSM. The root cause here is estrogen deficiency. Discharge can be scant, maybe white clear. Itching and burning can happen, but interestingly, it's often asymptomatic. The vaginal pH is usually higher, maybe over 5. And treatment. If you're symptomatic or getting recurrent UTIs, topical or vaginal estrogen is often the way to go.
What's really fascinating, just as you laid out, is how different these are. Different causes, different presentations, even if you initially feel similar symptoms like itching or burning. The key takeaway has to be that the discharge type, the odor or lack of it, and definitely those microscopic findings are absolutely crucial for getting it right.
Yeah.
Because, I mean, without that specific diagnosis, you just can't get the right treatment.
It really shows why trying to self-diagnose these things can be, well, pretty frustrating and ineffective. That distinction is so important. But what about when symptoms are less clear, or maybe not there at all, but the condition can still be passed on? That brings us to a really vital area. Sexually transmitted infections, STIs. Our sources are clear. Some STIs can mimic those common vaginal conditions or be totally asymptomatic. That makes awareness absolutely critical. Like genital herpes, right? Caused by human herpes virus 2, HHV2, the classic first outbreak. Painful, ulcerated lesions and noticeably swollen lymph nodes in the groin area. But here's the really crucial part, and maybe surprising for some. Asymptomatic transmission is incredibly common. You don't need visible sores to pass it on.
That's a huge point. People need to understand that.
Yeah. And management usually involves antivirals like acyclovir, famciclovir, or valacyclovir to help with outbreaks. Okay, next up. Non-gonococcal urethritis and cervicitis, often caused by chlamydia trachomatis. Symptoms might include irritative voiding, discomfort when peeing, and maybe a mucopurulent discharge. That's like mucus mixed with pus. But here's the kicker again. Often, no symptoms at all. Doesn't matter your gender. Treatment. Usually doxycycline or azithromycin.
That asymptomatic nature is why screening becomes so important in certain populations.
Absolutely. And similarly, gonococcal urethritis and vaginitis from Neisseria gonorrhoeae, similar irritative voiding, purulent discharge, and yes, you guessed it, often asymptomatic too. Doctors often start with a single shot of ceftriaxone. And smartly, if chlamydia isn't ruled out, they'll often add doxycycline just to cover both bases. Makes sense.
Covering the most likely culprits, yeah.
Yeah. And then there's trichomoniasis from Trichomonas vaginalis. This one has some really unique features highlighted in our sources. You might see a yellow-green discharge, sometimes even frothy, plus dysuria, painful urination, and itching, and sometimes those memorable strawberry spots on the cervix. Tiny red spots.
It's quite distinctive visually if present.
Right, and under the microscope, you can actually see the little motile organisms swimming around. A key point for treatment, usually metronidazole or tinidazole. Alcohol abstinence is vital. 24 hours after metronidazole, 72 after tinidazole, because the side effects can be pretty severe otherwise.
Good practical advice there. If we connect all this to the bigger picture, it just hammers home the importance of STI prevention and general sexual health, doesn't it? Because so many are asymptomatic, it really underlines the need for risk reduction counseling, understanding your risks, making informed choices. And if you are at risk, remember testing often goes beyond just the immediate concern. We're talking gonorrhea, chlamydia, HIV, syphilis, hepatitis A, B, C, maybe HSV2. Knowledge and proactive screening, they're really your best allies here.
We've talked about internal health, but what about something super common like urinary tract health?
Let's dive into UTIs. It seems simple, maybe, but treatment can have complex considerations, especially for non-pregnant women.
Okay, so the sources confirm the main player is E. coli, like over 75% of the time. But other bacteria can be involved too, right? Gram-negatives like Klebsiella, even gram-positives like Staphylococcus saprophyticus.
That's right. E. coli dominates, but it's not the only one.
And for treatment, it seems like local resistance patterns are key. If local E. coli resistance to TMPSMX is low, say under 20%, and you don't have a sulfa allergy, then that's often a first choice, TMPSMX-DS. But if you do have a sulfa allergy or resistance is higher where you live, then nitrofurantoin is a really common alternative.
Right.
And for just managing the symptoms, that burning feeling, phenylpyridine can help. That's the one that turns your urine bright orange.
It certainly does. But what's truly fascinating, and maybe not widely known, is how crucial those local resistance rates are. Bacteria evolve, What works great in one city might not be the best choice somewhere else because the bugs have developed different resistance. It really highlights how dynamic infection management is. Doctors need to stay updated on local antibiograms, those maps showing which drugs work best locally. It's all about the right drug for the right bug at the right time.
That makes so much sense. It's really tailored medicine. Okay, let's shift focus now to male genitourinary infections. They present differently, but just as important to understand. First, epididymo-orchitis, inflammation of the epididymis and testis. Here, age and risk factors seem to guide the thinking on causes and treatment. For younger guys, say 35 or under, or those engaging in anal intercourse, it's often STI-related, like Neisseria gonorrhea or Chlamydia trachomatis. Symptoms include that irritative voiding, fever, painful swelling in the scrotum. But for older men or those with other risk factors, it's more likely Enterobacteriaceae. Those are common gut bacteria. And there's a helpful diagnostic sign, Prien's sign, where lifting the scrotum actually relieves some pain, that helps differentiate it from something like testicular torsion, which is an emergency.
A very important clinical clue, yes.
Then there's acute bacterial prostatitis. This sounds pretty unpleasant. Distinct symptoms like pain above the pubic bone in the perineal area between the genitals and anus, plus fever. And on exam, the prostate might feel tender and boggy, like soft and swollen.
Boggy is the classic description, yes. Soft edematous.
Again, treatment seems to depend on age and STI risk versus uncomplicated cases. For low STI risk, maybe esciprofloxacin, levofloxacin, or TMP-SMX.
Correct. Targeting the likely pathogens in that group.
Okay, and just briefly, a couple of other relevant male GU conditions. Genital candida, so yeast in men. It typically shows up as balanitis inflammation of the head of the penis, maybe involvement in the groin folds, scrotal irritation. But crucially, the source is stress, not usually penile discharge.
That's a key differentiator from something like urethritis.
Right. Management often involves topical miconazole. And importantly, checking blood glucose is recommended, especially if there are risk factors like obesity, because it could hint at undiagnosed diabetes.
It can be an early warning sign sometimes.
And benign prostatic hyperplasia, BPH, super common as men age. What's consistent is the prostate size, maybe 2.5 by 3 centimeters or larger, and symptoms like trouble urinating often improve a lot with alpha-1 blockers like tamsulosin. What seems inconsistent, according to the sources, is jumping to surgery too early. That's usually a later step.
Generally reserved for when medications aren't enough or there are complications, yes.
And finally, prostate exam findings. There are some helpful analogies. A normal prostate feels like the tip of your nose, firm but slightly yielding. Acute prostatitis might feel softer, tender, maybe like your cheekbone.
That tenderness is key in prostatitis.
And prostate cancer can feel nodular and firm, but the important point is malignant lesions often aren't palpable until the cancer is pretty advanced, which really underscores the need for screening, not just relying on the exam.
Absolutely. It highlights the limits of the physical exam alone for cancer detection. And this all raises an important question, doesn't it? Why is careful differential diagnosis so critical in both male and female GU health? You've given such clear examples of how similar symptoms can point to vastly different problems. The core insight really is that these systems are incredibly interconnected. Without pinpointing the exact cause, you risk misdiagnosis, ineffective treatment, maybe even missing something serious. It's like being a medical detective, putting all the clues together.
That medical detective idea leads us right into another really common issue, one people often don't talk about much: urinary incontinence. And it's not just one thing, is it? The sources show there are different types, each with its own causes and management strategies. Okay, first, urge incontinence. This is apparently the most common type in older adults. It's that strong, sudden urge to go right now that you just can't suppress, leading to involuntary leakage.
That sudden, overwhelming urgency is the hallmark.
Treatments include things like behavioral therapy, bladder training, and medications called antimuscarinics, though they can have side effects, right? Like
Right.
dry mouth, constipation. But there are newer options too, diphtheria agonists, which work differently and might have fewer of those side effects.
Yes, offering more choices for patients.
Then there's stress incontinence. This is the most common type in women. It's leakage that happens with activities that increase pressure inside the abdomen, like coughing, sneezing, laughing, exercising, often due to weakened pelvic floor muscles. Management includes pelvic floor exercises, Kegels, or supportive devices like tampons or pessaries, and sometimes surgery might be considered to support the bladder neck.
A very different mechanism than urge incontinence.
Completely different. Then functional incontinence. This is more about the inability to get to the toilet in time, or not being aware of the need to go, often linked to mobility problems or cognitive issues like dementia. Here, an assistant who can spot the cues and help is often crucial.
It's not about the bladder itself malfunctioning, but the logistics of getting there.
Exactly. And finally, transient incontinence. Like the name suggests, it's temporary, linked to an acute event, maybe a UTI, delirium, even certain medications. The good news here is you treat the underlying cause and the incontinence usually goes away.
That's a really hopeful category.
Yeah.
And to help remember those treatable causes of transient incontinence, there's actually a really helpful mnemonic our sources mention. Diapers.
Diapers. Okay, what does that stand for?
It stands for delirium, infection like a UTI, atrophic urethritis and vaginitis, pharmaceuticals, certain drugs, psychologic disorders like depression, excessive urine output from diuretics or diabetes, restricted mobility, and stool impaction.
Wow, that covers a lot of bases. Diapers.
It really does. And this diapers mnemonic brings up a huge point. For so many people, incontinence feels permanent, maybe embarrassing. But the core insight here is that incontinence is often not permanent. It's a symptom. It's a critical clue your body's giving you that something else needs attention. Once you find and address that underlying cause, the eye for infection in diapers, for example, the incontinence very often resolves. It offers real hope for people who might feel resigned to it.
That's such a critical perspective, seeing it as a symptom, not just the problem itself. And that need for precise diagnosis leads us right into our next vital area: screening for GU and GYN cancers, and also HIV prevention. Okay, starting with HPV-associated cancers, specifically cervical and anal cancers. For cervical cancer screening, the guidelines generally suggest starting around age 21 or 25. Screening can stop at 65 if you've had consistently negative results. And even if you've had the HPV vaccine, you still follow the standard guidelines.
That's important. The vaccine is protective, but screening is still necessary.
Right. And screening needs to be more frequent for high-risk women, those who are HIV positive, immunosuppressed, or had DES exposure back in the day. Also, some nuances after hysterectomy. If the cervix was removed and it wasn't for cancer or precancer, screening can stop. But if the cervix is still there, or the hysterectomy was for cancer precancer, screening continues.
Makes sense. Depends on whether the target tissue is still present or the prior risk.
And for women with a history of CIN 2 or 3, those precancerous changes, they need continued screening for at least 20 years after it was found, often more frequently at first. Screening usually involves a pap test, sometimes with HPV co-testing.
Right, that long-term follow-up is key after treatment for precancer.
Okay, now for anal cancer screening. Routine testing isn't recommended for average risk folks, but anal pap tests can be considered for high-risk groups. That includes people living with HIV, those who receive anal sex, anyone with a history of anal warts, or women with a history of cervical or vulvar cancer. Frequency differs too, maybe annually for HIV-positive individuals, every 2 to 3 years for HIV-negative individuals in these high-risk groups.
So targeted screening based on specific risk factors.
Exactly. Now, moving to other female reproductive tract cancers, endometrial cancer, risk factors include obesity, PCOS, the main sign, abnormal vaginal bleeding. Our sources confirm there's no specific screening test, so being alert to symptoms like abnormal bleeding is really crucial.
Symptom awareness becomes the primary tool there.
And for ovarian cancer, risk factors include those BRCA1 and BRCA2 gene mutations. The challenge here is presentation, often no significant signs until it's quite advanced. And again, no specific screening test is recommended for the general population.
Which is why it remains such a difficult cancer to detect early. This really raises an important question, though. Why do we screen for some cancers like cervical, but not others like ovarian or endometrial in the general population? It really comes down to the power of early detection and effective intervention. For cervical cancer, we have Pap tests and HPV tests that can find precancerous changes. We can treat those changes before they become cancer. That makes population-wide screening effective.
Oh, okay.
For ovarian or endometrial cancer, we currently lack tests that are sensitive and specific enough to find them early in everyone, without causing too many false alarms or unnecessary procedures. So for now, understanding risk factors and recognizing symptoms is paramount for those. Research is ongoing, of course.
That distinction makes a lot of sense. It's about having a tool that genuinely works for early detection and prevention on a large scale. Okay, finally, let's cover the essentials of HIV management and prevention. These are just fundamental to sexual health today. For people living with HIV, antiretroviral therapy, ART-T, should start as soon as possible after diagnosis, and it's lifelong. But here's the truly transformative insight from the research. ART isn't just for the person's own health. It's an incredibly powerful prevention tool.
Absolutely game-changing.
Yeah. When someone on ART achieves an undetectable viral load, you hear the phrase UU. It means HIV is literally untransmittable to a sexual partner. That's huge. It removes so much fear and stigma, and it's massive for public health.
U is a revolutionary concept, scientifically proven.
Then, for HIV-negative individuals who are at substantial risk, maybe through injection drug use or sexual activity, there's pre-exposure prophylaxis, or pre-AP. That's usually a daily pill taken as long as the risk remains high. And lastly, post-exposure prophylaxis, PP. This is for an HIV-negative person after a single high-risk event. Think of it as an emergency measure. It needs to be started ideally within 72 hours of exposure and is taken for 28 days.
So different tools for different situations, ongoing treatment, ongoing prevention, and emergency prevention. And reinforcing this message is just so critical. Knowing about these strategies, ART-T as treatment and prevention, PIEP for ongoing prevention, PEP for emergencies, is absolutely key to driving down transmission rates and improving public health everywhere. These aren't just medicines. They are, in a real sense, instruments of liberation, and they pave the way for a much healthier society.
Wow. We have covered an incredible amount of ground in this deep dive, from, common discomforts like vaginal issues and UTIs, all the way to critical cancer screenings and these really life-changing HIV prevention strategies. It's a lot, definitely. But hopefully each piece helps build a clearer picture of your body and your health. Our real hope is that you feel more informed now, maybe more empowered to ask specific questions when you see your doctor, and more confident knowing when you should seek attention for these topics, which, let's face it, can feel sensitive. Because being informed, that really is the first step towards better health.
Absolutely. And as you think about everything we've discussed, maybe consider this final thought. Reflecting on the distinctions we talked about today, the specific signs, the different conditions, what single sign or symptom, even a subtle one, would now prompt you to seek medical advice, either for yourself or maybe for a loved one. Your body gives you clues all the time. Learning to interpret them, based on solid information like this, can truly make all the difference in getting timely, appropriate care.